Stable angina. Etiology and pathophysiology and pathology. Atheromatous plagues in the coronary arteries reduce blood flow. The myocardial oxygen supply cannot meet the demand, resulting in myocardial ischemia and chest pain, angina pectoris. Epidemiology. The prevalence of angina in the UK is estimated as 3% of the population, i.e. 2 million individuals. Clinical presentation. Common. Predictable exertional central chest tightness. Worse in cold weather and after meals. May radiate to jaw or the left arm. Pain resolves with rest. Uncommon. Exertional dyspnea, angina equivalent. This is more common in females. Physical signs. Examinations are often normal, but watch for signs of aortic stenosis and anemia, and check the peripheral pulses and BP. Investigations. Figure 34 shows an investigation algorithm. Resting ECG, this is often normal and does not exclude coronary disease. Exercise ECG, this may show exercise-induced ischemic changes, confirming the diagnosis and giving objective evidence of exercise capacity and prognosis. Stress imaging includes myocardial nuclear perfusion, stress echocardiography, and magnetic resonance stress imaging. This may be used in patients unable to exercise or who have bundle branch block. Cardiac catheterization. Blood tests, FBC and fasting lipids. Patients who have chest pain without diagnostic ECG changes during exercise testing may have important coronary disease. It is important to stratify patients by their presentation and risk factors into low and high risk groups. Patients at high risk of CAD with exertional chest pain but without diagnostic ischemic changes should proceed to diagnostic cardiac catheterization, Fig 35. Those at low risk of ischemic heart disease should undergo stress imaging to search for ischemia. If these investigations demonstrate ischemia, then cardiac catheterization should be considered. Treatment. Lifestyle advice. Encourage regular exercise. Prophylactic sublingual glyceryl trinitrate, GTN, administered before exertion may be helpful. Stress the importance of stopping smoking. Medical therapy. First-line therapy is with aspirin, GTN spray, beta blockers, and a statin. Angiotensin-converting enzyme inhibitors should be prescribed to patients with normal left ventricular function and ischemic heart disease. Revascularization. There are two methods of revascularization: coronary artery bypass grafting, CABG, and percutaneous coronary intervention, PCI, involving angioplasty and stenting. Currently, the evidence is that CABG confers prognostic advantage in certain groups, with diabetics showing a particular improvement in left main stem stenosis, more than 50%, proximal left anterior descending stenosis, more than 70%, 3-vessel disease, especially with impaired left ventricular function. PCI is carried out more commonly than CABG, and is currently indicated for symptomatic stenoses of more than 70%. At present, an improvement in life expectancy has not been demonstrated, but trials are ongoing. Patients who are unfit for CABG may be considered for PCI. See Fig 36 for an investigation algorithm. Prognosis. Generally, stable CAD confers a good prognosis. Cardiac catheterization of patients identified to be at high risk by non-invasive stress testing will identify those with prognostically important disease. NB. Important information for patients. The condition is stable. There are important narrowings in the arteries. Continue exercise but avoid strenuous exertion, especially heavy lifting. GTN before exertion may be helpful. Chest pain at rest continuing for greater than 15 minutes despite GTN warrants immediate hospital admission.